All right. So today we are going to discuss theory development in nursing. I'm trying to move this away. Yeah, can you all see the screen?
Yes, sir.
Yes, sir.
All right. So theory development in nursing. But before we start, I would like to hear your feedback. When you hear about theory, what comes to your mind? Theory, we've been talking about theory from bachelor's to master's and now PhD for some. What comes to your mind when you hear theory? Um, I may call names if you guys don't talk. So I'm gonna call Bossel Jenniron. I'm sorry if I call you and you're a faculty, please. Pardon me. Bossel Jenniron, what comes to your mind when you hear theory? You guys are not talking. This is going to affect our class if you don't talk. Pastor Janiro, you are muted. And if you don't talk, I may have to remove you from this class.
Good afternoon, sir. I'm
Pastor
online. I've
Janiro,
just joined. Good afternoon, sir.
is that Pastor Janiro? I called Pastor Janiro.
Okay, all right.
All right. Any other person who can tell me what theory represent? What comes to your mind when you hear about theory?
Yes, sir.
Okay.
I will say theory is like a framework
Okay.
that guides the practice of nursing. It defines the scope of nursing practice, what nursing is, what it does, and how it should be practiced. Thank you, sir.
Abso Absolutely. Victoria Faremi, um, what is theory? What comes to your mind? But I think, okay, let me skip Oluremi. I don't know if it's longe or longo. What comes to your mind when you hear theory?
Theories provide framework
Okay,
for us to understand complexities of the care of patients, they guide our practices, and also help to improve outcomes.
absolutely. So basically, theory is a set of framework or guide or a map that gives us direction as to what to do in nursing and also provides rationale for some of the things we do. It's like a map when you're traveling to Lagos or traveling to any complex city. It may be difficult to navigate the terrains of that city. So you may need a map or like Google Map or whatever that will be guiding you. Okay, when you get to this junction, take right. After 2 miles, take left. So that is what theory is all about. Now, okay, something is going on here. Uh, my screen. Let me stop sharing and start again. Yeah. Yeah. I think this is better now. So the definition of theory, there are multiple definitions of theory. Okay. But then generally we see theory as a conceptual framework that helps us to organize knowledge and also provide basic guidelines to the practice of nursing. Now, you ask yourself, why do we do theory? Because generally theory is very abstract. It's very conjectural to a practical, thing that we do. Why then do we do theory? From existing knowledge, we found that theory actually guides practice. For example, when we are engaging in difficult conversations, we want to talk to patients who are difficult to understand, or patients from different backgrounds, different mental states. To communicate with them can be challenging. But then, when we use the theory of interpersonal communication, it tells us that, okay, before you even go into the business of the day, you have to create a rapport. You have to start with the introduction. You have to, understand the patient. The patient understands you. Create that friendship. Otherwise, it's not going to work. So, with that knowledge, before we do anything, we have to establish that baseline interpersonal connection with a patient or with anybody. It doesn't really have to be a patient, with anybody. Okay. Theory also helps to clarify the role of the nurse in patient care. Sometimes the nurse will act as an advocate. Sometimes the nurse will act as a teacher. Sometimes the nurse will act as a novice, depending on your level. We have the novice to expert theory that tells us that, okay, before you become an expert, you start from somewhere. And the expert will already understand the complexity involved in being a novice, so that they would also put themselves in the shoes of that novice nurse, so that you don't expect somebody who has just graduated from school to be doing everything, to know everything. That will be unrealistic. Of course, if we don't have a theory to guide that, many people would expect junior nurses to do everything. Okay, it takes step from novice to advanced beginner until you graduate and become an expert. That is what theory tells us. So now, why do we do theory development? What is theory development itself? Development of theory, since we've understood what theory is, the development of that theory is just a process that helps us to create, evaluate, and refine theoretical frameworks or models. And these models will be used to describe, explain, predict, or guide nursing practice. We have multiple theories in nursing, and these theories did not come from heaven. They were created by individuals. And if you read through the history and then the genesis of most of these theories, many of them developed their theory when they were doing their PhD programs, or it started, at least the conception started during the PhD program. So at the end of this class, you should also be, conditioned to start thinking about developing your own theories. As a matter of fact, if we had enough time, all of us will become a nurse theorist at the end of this class, but there's no enough time. So we will look at how we can go around that. So generally, because we know that theories help to organize knowledge, guide our decision making, so the theory development should also be structured in such a way that it will guide the decision making of other nurses who may be using our theories. Now, historically, we know that theory started long time ago in the 18th centuries. Started with Florence Nightingale when she wrote her work on Note on Nursing, what it is and what it's not. So she laid the foundation of how certain conceptual frameworks will be able to guide our practice. Until today, we still utilize Florence Nightingale's idea in helping to organize our environment. She is a big proponent of how to control the environment in order to bring a positive impact on our health. And then later on, we moved to the 1950s. We talked about, Virginia Henderson, who was the one that defined what nursing is. Can somebody still give me the definition of Virginia Henderson? Now, as theorists or nurse theorists or students who are learning theory development, you can't help but know different theories, at least the names of the authors and what the theory is all about. So you have to know about 100+ theories in your head because you can't start from nowhere. You have to build your theory on existing theories. So you have to have a good grasp of what those theories are talking about. Now, who can define Virginia Henderson's unique function of a nurse? It's a common definition that everybody knows. So, yeah, who can try? Who can try, please? I learned this thing over 16, 17 years ago, and I can still tell you word for word what Virginia Henderson's definition of nursing is. The unique function of a nurse is to assist individuals, sick or well. Okay, I think Boss Janiro is back. You found your way back. So I'm going back to you. Do you want to unmute and define the unique function of a nurse?
Good afternoon, sir.
Good afternoon. Yeah.
Hello, sir.
I can hear you. Go ahead.
Hello, sir. The unique function of a nurse is to give a holistic care to our clients.
Okay. Was that according to Bossel Janino or by Virginia Henderson?
Hello, sir.
Yeah.
Ellen wants to
Helen.
speak, sir.
Okay, go ahead.
Ellen wants to speak, sir.
Go ahead.
Okay.
Hello, sir.
The unique function of a nurse is the contribution. Is that activity that contributes to the health or recovery of a patient from his or her sickness or to a peaceful death.
Okay.
Can you hear me, sir?
Yeah, I can hear you. Yeah, you tried, but not quite there. Let me hear from Ishola Kofora.
Yes, sir.
Yes, sir. Good afternoon, sir. So,
Good afternoon.
Virginia Anderson defined nursing, the unique function of a nurse as assisting the individual sick or well in the performance of activities that will contribute to the health or recovery or to peaceful death of the patient, in such that the person would have performed unaided if he had the necessary strength, skill, or knowledge.
Absolutely, that is perfect. And to do so in order to gain independence as quickly as possible, that is also part of the definition, right? Now, you see that definition is loaded and we still apply it up till this moment. Now, with the people we care for are not all patient. It's not all the people we care for that are patients. Some are just our clients. We do health education, health promotion activities that do not involve sickness. And that's why Henderson's definition says the care of individuals sick or well. So we care for those who are well for them to maintain their health. And then she also, the later part of her definition talks about helping them to gain independence. So, which means while we care for patients, we are always assessing their level of independence in performance of self-care activities. So, if they are dependent, you do for them. And if they are independent, you allow them to do those things by themselves. And you always train them to become independent at all times. Now, if you look at it downwards a little bit, we'll talk about Dorothea Orem's self-care theory, which also has a little connection with Virginia Henderson's theory that talks about self-care theory. And there are three nursing actions that we do: wholly compensatory, partly compensatory, and supportive education. Only compensatory are for those that when the patient is not able to perform those activities at all, the nurse will be there to supplement, not supplement, the nurse will be there to do those activities for the patient. For example, if you're caring for a patient who is in ICU, who is unconscious, what happens? You are the one that will do everything for the patient, including taking shower, eating, movement, mobility, everything. The nurse is responsible for doing almost 100, let's say 99% of those activities of self-care. But somebody who has recovered is now in medical ward or in step-down unit or wherever, and the patient has recovered to an extent, you have to assess, okay, are there things the patient can do by themselves, or are there things I will do for the patient? By the time you make this judgment, you determine, okay, you are going to move, I'll just watch you. You feed by yourself, okay? And yeah, but then your fluid, since you can't drink water now, I'll have to give you fluid through IV. You see that you are now doing supportive or what we call partially compensatory nursing. The patient can do some while the nurse can do some. And when you put everything together, it gives a total care for the patient. Now, there are patients who have recovered, they are free, all they need is education. For example, during discharge, you give them education. Okay, this is what you need to do this and do this. Make sure you have exercise. The patient can do everything by themselves, but then they need some supportive education from the nurse. So you see that even though this theory was propounded in 1952, it's still relevant up till today. Now, I will ask you, how would you feel if you go for, let's say, you hurt your small toe while going to class, and you go to the hospital, and the nurse is feeding you with a spoon directly in your mouth? How would you feel? Let me say, Oluremi Longe, can you answer? How would you feel? You just have a scratch on your small toe. Is that?
Hello, sir. I'll feel uncomfortable.
Why?
I won't even allow her. I won't even allow her to do that because I can do all those activities by myself. It's only that
Absolutely.
my little toe.
Absolutely. Now, but the nurse may be caring. I'm just trying to help you. I'm trying to help. I'm trying to do everything for you. It may be that is inappropriate, even though the nurse is trying to help, but then is helping in a wrong way. And that is not considered nursing. Nursing is you have to assess what the patient can do by themselves, and then you help them to do those things they can't do. Okay, now going back now to still the 1971, we still see the theory of Imogen King, goal attainment theory. It's talking about transactional process between the nurse and the patient. That when the nurse comes, the nurse has his or her own perception, orientation, her fears, impressions, everything personal to the nurse. The patient also has his or her own perception, has his or her own interest, everything personal to the patient. However, when they come together, the goal of the nurse and that of the patient, the perception of the nurse and that of the patient has to be combined, has to be harmonized in order to bring an action. The action will result into interaction. The interaction will result into transaction, and transaction will result into goal attainment at the end of the day. You see, that theory is one of my best theories, Imogen King's goal attainment, because it tells you that you have to be at the same wavelength with your patient in order to initiate an action. And that action could be, okay, you have diabetes, we'll start by doing this, we'll start by doing this. And the nurse will say, oh, the patient will say, oh, I don't have money, that's why I'm not compliant. Then from that point, you can understand how you can harmonize the patient's issues. Then that is interaction. No, that is action. Then from interaction to transaction. By that time, you'll have achieved, the goal, and then you can do evaluation. Now, look at the four theories that are projected on this screen: the Virginia Henderson, Peplau Interpersonal, Dorothea Orem, Imogen King. There's something common among them. So these are the theories that were developed within the 1950s and 1980s. Now, moving down, still within that range, we now have some of these newer theories. John Watson, that talks about human caring, that says, okay, it's not all about all those activities that we do, the vital signs, the brushing of the mouth, the self-care. There is also this sense of empathy, the sense of healing relationships, sense of kindness and respect. John Watson is somebody I love so much. I love her theory so much that I met her on I met her in October last year in Washington, D.C. during my induction as a fellow of the American Academy of Nursing, and she was so happy because I've been in contact with her for so many years. So when I told her I was the one we've been working together, and she never knew me in person, she was so excited too. Yeah. So she did not only propound the theory, but it's part of her already. If you see how she gave me a hug, how she was just so passionate about meeting somebody who has known her for so much, for a long time. You see that sense of human caring within her. Okay, and then Betty Newman's model talks about how the human system is an open system interacting with various internal and external environments, and this interaction will bring stress. And the role of the nurse is to help the patient to overcome these stressors, because it is the stress that brings illness. Okay. In 79, Magdalene Leninger also introduced that theory, and this was the theory I used for my PhD, which was the theory of transcultural nursing. It's been changed now. It's called theory of culture care, universality, and diversity. Okay, talks about how we should be culturally congruent when we are caring for our patients, to be culturally aware, be respectful of people's culture, not just to respect their culture, you should understand them and also perceive what they are perceiving from their own lens. Okay, that is what their theory talks about. So later on in the 1960s, we had a different type of theories. The Patricia Benner's novice to expert theory, which I've explained earlier, that tells us that, okay, we have to graduate from one level to another. As a matter of fact, the internship we are doing right now in Nigeria and everywhere in the world is enshrined within Benner's theory. Because when a patient graduates, it's just impossible to tell the patient, okay, go to the ICU and start working on your own. That may be impossible. But then starting with like novice, then going to advanced beginners, they graduate until they become expert. Okay. So that makes us, that's why one of the reasons why internship is initiated, so that the students who have graduated can now start as advanced beginners and then graduate to becoming experts later on. Okay. And then Swansea's, I think this is altered, but then Christine Swansea's theory of caring also emphasized the 5 caring processes: knowing, being with, doing for, enabling, and maintaining beliefs. So our own idea is that before you do anything for a patient, you have to know the patient. And knowing, of course, you know that there are different types of knowing. I'm sure you have learned that from the philosophy of nursing that you learned. The different types of knowing. We have the empirical knowing, we have the moral knowing, and there are four other types of knowing. So you have to know the patient, and then two of you will have that sense of being with. So when you have that sense of presence, nursing presence, then you can now do for the patient. Doing for the patient could be giving education or based on their level of self-care need. And then you enable them to do those things by themselves. Remember, it is also connected to the things we've talked about in the past. And then you maintaining beliefs is whatever they've learned, they should build on their current practices. And that will continue to promote health. And these are basis of nursing practice that we do today. So before you do something for a patient, what about knowing the patient? Not by their bed number, but knowing them as individuals, as human persons. Okay. What about knowing them in terms of taking thorough history of what is going on in their body system? By the time you start talking to them, two of you will start connecting. That is being with. Okay. Now, Nola Penda's own is about health promotion, okay, and focuses on disease prevention and how to help the patient to maintain health and prevent illness. That is also coming, it has a connection with Betty Newman's system model that talks about holistic approach, how to avoid stressors, and those stressors, if not avoided, can lead to diseases. So generally, you have to have a good grasp of the essence of some of these theories for you to be able to build your own theory or even understand the concepts within each of their theories. Now, this is just a little background of the origin of these theories that we are talking about that we'll be hearing. And we sometimes people say, why do we really do theory in nursing? Now, connected to theory is philosophy. Because theories have to do with your convictions. Theories have to do with how you see the world, how you see things. And then you now say, okay, based on the way I see things, this is how it should be done. And if it's been tested, then people can start doing it that way. Of course, there are so many theories that we don't even know much about them today because they didn't stand the test of time. For example, there's a theory we call the core care cure theory. Core care cure theory, nobody really talks much about it today because over time, people have not really seen that, the value. Okay. Now, there are so many other theories that have been propounded that people still don't talk much about them. Not that they have failed or there are no ideas in them, but because people, as, things continue to emerge or the world continues to evolve, some of these theories will lose relevance and then new theories will come up. However, this theory, for you to develop theories, you have to be grounded in your own personal philosophy as a human person, grounded in your own philosophy as a nurse, and that would now make you to have a way of understanding theory. Ishola, you have a question?
Yes, sir. Sorry to
No, it's
hop
okay.
in, sir.
It's okay.
There are some of our classmates. They've been sending messages that even with the passcode, some have not been able to join the class, sir.
This is
Hello, sir.
interesting. This is interesting. How many of them?
Let me check on the group. Like 4 now or 5. There are 5 of them. 1, 2, 3, 4. About 5 of them, sir.
They do not have Zoom. They do not have Zoom
Okay,
in
sir.
their this thing.
Okay, sir. So I should advise that they download the Zoom app and
Yeah,
then
you can't join Zoom without yeah. They said the host requires authentication on the commercial Zoom platform to join this meeting. Please sign in with the commercial Zoom account to join your meeting ID. Let me see what's going on. But you guys, it was so easy for you to join.
recording in progress. I think some people had to use the passcode too.
So it was difficult to join too, but I later got through.
Likewise, for my own end, I find it difficult to get connected initially. But at last, I was able to get connected. Thank you, sir.
Yeah, how did you get connected? Was it through the link or this thing? So is everybody on that health service research platform?
Not everybody, sir. But
Yeah.
even those that are not there, they've gotten the link.
Yeah. Because I'm surprised we have just hold on. Let me see the unique. Okay. I'm gonna stop sharing and see. So we have how many people on the call? 21 people. So if 21 people were able to join, then I think it's a personal situation. Because if nobody had joined, then that would have been a problem with the link or something. Uh, people have to have Zoom on their what's it called, on their devices before they are able to join. And if people have been using Zoom to do classes before, so it shouldn't be a problem. All right, I see new people joining. I don't know who is Intel S685LN. Was it difficult for you to join? Mrs. Shola, when you joined, what happened? Did they give you issues personally?
No, sir, I didn't.
Yeah, so yeah, I think people have to, yeah, more people are joining now. More people are joining. So they have to sign in to join. I think that's why they have to sign into Zoom. And every graduate student should be conversant with Zoom. Yeah. All right, I think we can continue now. We have more people. We have 24 now, and nothing changed. We didn't do anything. So I think they just have to download the Zoom on their devices before they can join. Can we continue?
Yes, sir.
Yes, sir.
All right.
Yes, sir.
Let me go back to Hope. All right. So, back to what we're saying, the philosophical underpinnings of nursing theories. Nursing theories are built on certain philosophy, and these philosophies guide the way an individual, even a theorist or nurses, see the world. Okay? They are foundational beliefs as to how nursing should be practiced and how we should see the patient and how the nurse-patient relationship should look like. For example, If my philosophy is that human beings are, everybody is a human being, regardless of our status. Sorry, I have to remove this captioning. Yeah, if my philosophy is that everybody is a human being, regardless of their status, that means that when I'm caring for anybody, regardless of who you are, if you like be a homeless person, I will care for you the same way I will care for somebody who is a politician or who is influential. Okay, that guides the way you practice nursing. If your philosophy is that everybody has the right to self-determination, everybody has the right to make decisions about themselves. If that is my philosophy, and when I'm developing a theory, the theory I will develop means that the patient will be an active participant in their own care. It will even be the expert and not the nurse or the doctor. The doctor is a professional, but it cannot be an expert in somebody's personal situation. For example, when I am prescribing a medication, or when I'm giving a medication to a patient, and the patient says, "Oh, this medication, I don't like it," and it's the patient that experiences that symptom. So that will make me to understand what the patient feels and try to see how we can, maybe give an alternative. But in some cases you say you have to take it. That's the only thing you can take. Just manage it like that. Just take it. You are not the person feeling it, and that means that you should also understand from the perspective of the patient who is undergoing that situation. So that is how philosophy guides the way we view things, the way the nature of nursing, the nature of the person we are caring for, and then the nurse-patient relationship. Philosophy guides everything that we do. Now, there are different types of branches of philosophy. We will start with the ontological perspective, the nature of being. What is the nature of being? What is the nature of reality in nursing? How is nursing? What is the essence of nursing? Yeah. So this ontological perspective questions the nature of the nurse, the nature of the patient. Hello?
Yes, sir.
Yeah, somebody was saying something.
Hello, sir.
Hey. Yeah. Are we on the same page?
Yes, sir.
Yes, sir.
So I'm getting
Yes, sir.
I'm getting some distractions. So I'm trying to understand what's going on. Okay. So ontology is just the nature of reality, the nature of being in nursing. And under the ontology, we have different, types of philosophy, different philosophical views under ontological perspective. The first one is humanism. Humanism is an ontological view that sees a person or human beings as being holistic entities. So, which means they are comprised of physical, emotional, spiritual, and psychological dimensions. So, when you are caring for a patient that has cancer of the let's say of the liver cancer, it's not only the liver cancer we are dealing with. We're also dealing with some psychological issues. We're also dealing with some spiritual components. We are dealing with emotional. I have just written a book. I called it United as Human, Divided by Cancer, because my specialty is I work so much on oncology care. So in that book, I explored how the different parts of the human being is affected by just a single organ cancer. Okay, so it is just a product of the humanism that views a human being as being a holistic entity that has multiple dimensions. Now, the next one is the relational ontology, which is also the ontological perspective that suggests that nursing is fundamentally relational, emphasizing the interconnectedness between the nurse and the patient. Now, if you are caring for a patient with this perspective, how does that influence your on your nursing care. Shekinat Itsuoko, if you're working with an ontological perspective of relational ontology, how would this influence your nursing care? Shekinat,
Yes, sir. Good afternoon, sir.
good afternoon. Yeah.
Yeah, it's going to influence it positively in terms of caring for the patient, the way it should be by maybe showing empathy, because when you are caring for such patient, you have to really put more of your best to it and do the necessary care to the patient that will promote the patient's healing and also try to encourage the patient on the condition in which the patient is going through. That is my feeling about that, sir.
Yeah. Yeah. Perfect. Um, I'm not able to see everybody. That's why I keep calling the people that pop out on my screen. Just give me a second. Let me address a comment on the. Someone said logged out again. I don't understand how the being logged out is a problem. It could be your network. Um, Someone said it was with struggles before we joined. What does that mean? Like, I have tried several times since 2 minutes before one. This I still can't join. Okay. Um, do you think it's safe for me to send a new link?
If that will help, sir, you can do that,
Yes,
sir.
sir. Maybe we should all
Just-
join the new link, sir.
Okay. Let me
Yeah.
let
Let's do
me
that, sir.
let me use we can use Google Meet, right?
It's okay,
Better,
sir.
sir.
Good.
Yes, sir.
All right. Yeah.
Sir, will you be able to record, sir?
I won't be able to record in Google Meet. So, unfortunately.
Okay. Please give me a few minutes, sir. My laptop is upstairs. I'm outside somewhere. I can record on my own Google Meet, so I'll form the link and
Okay.
send it, sir.
Okay, perfect. Perfect.
Yes, sir.
All right.
I'll send the link, sir.
Hello, can you hear me?
I've sent the link, sir. Sorry, I think the network went, but I've sent the link.
Yeah, I think I said I found what the problem was. So
Okay, sir.
let's continue. I had to go back to the setting and I clicked only authenticated users can join. That was the setting before, but I've removed that.
Okay, sir.
Oh,
Yeah,
okay.
yeah. Let them try again and join. Let's see if it's gonna work.
All right, sir.
Yeah, let's just hold on a little bit. Let me pause. So as I was saying, living beyond the present means that especially when it has to do with the theory, Margaret Newman's health as expanding consciousness theory. It says that health is not polarized. It's not about being healthy and being ill. To this different, we say health is on a continuum, but Margaret Newman does not view health as being on a continuum. It says that both health and illness are integral parts of human existence. So when somebody is having an illness, the person is living out a pattern of life. When the person is healthy, the person is also living out a pattern of life and should not be seen as something, something different. Both the good and the bad are all patterns. That the life is not on a straight, on a linear perspective. It oscillates. It moves up and down, moves up and down, and people should also view it in that perspective. So when somebody is ill, you should not see the person as being less than a human being. Even when somebody is dying, for example, I've taken care of I've done hospice care a couple of times, and I've taken care of dying patients. They already know, okay, I have a month, I have 2 months to live. So you can only give them the best at that moment. But then your care to that patient should not reflect as if the patient is less than a human being, or the patient has been condemned. No, the patient has to be treated with dignity, with respect, as every other human person that you are caring for. So her theory is coming from a different perspective of a metaphysical perspective beyond physical, and more of spirituality, how we view things, how we transcend beyond the physical realm. Some people, when they are dying, you see them, they start reflecting on their lives, they start reflecting on where they are going to, how they are going to, different things. These are how Margaret Newman views reality. Okay. Example is we've talked about Margaret Newman's and how she reflects on a metaphysical perspective of nursing the human spirit and sees illness as an opportunity for personal growth and expansion of consciousness. I've seen people who, by the time they are ill and they recover from it, they become a better person. I've seen people who, when they experience difficult situation and they recover from it, they become better, they improve, they transcend beyond. Okay, they see life as not something you should take so tightly, as if it's a do or die thing. That life should be a free free movement, a free activity. There are people who come out, they become better persons, they live, they have this sense of personal growth, sense of transcendence and expansion of their consciousness. So that is what the theory Margaret Newman's health as expanding consciousness talks about. Feminism and social justice, I'm gonna skip this. Just talking about theories of philosophies that are grounded in the principles of feminism and social justice. You should do good to people, including we are talking about climate change. It's a social justice issue. We are talking about health disparities. They are all social justice issue. So these theories help to address some of these issues that we have. So these are the summaries of all the philosophy we've talked about: the ontology, epistemology, ethics, axiology, methodologies, metaphysics, and social justice and feminism. So ontology, nature of nursing and human existence; epistemology, how knowledge is derived; ethics, what is the value of morals; and then axiology, what the values that are considered fundamental in nursing. Especially caring is a fundamental thing that we consider to be important in nursing. Methodology, how we approach our research inquiries. Metaphysics, living beyond the physical into the spiritual realm. And then social justice and feminism. Now, nursing paradigms, it's also drawn from the philosophy we've talked about. When you say paradigms, I'm sure you have heard about paradigm shift. We've heard about different, I'm sure, paradigm is not a new word to us. Nursing paradigm is how we view reality, how we view things. Well, what is the nature of reality? For example, if I'm wearing a Google that has a blue lens, what do you think the world will look like? What is the color of the world? What will be the color of the world when I'm wearing a blue lens?
Blue.
Now, if the world is blue and somebody else is wearing a red lens, what is the color of the world according to the person wearing a red lens?
Red.
Now, that is from our own paradigm, and there's nothing else you tell me that will make me believe that the world is red because I'm wearing a blue lens. And you are wearing a red lens, so tell me the world is red. So that is paradigm. How we see the world will determine how we approach it. Now, if you view a person as being let's say, has the right to self-determination, if your paradigm views a person as an entity that has a right to self-determination, that will make you to always hear the perspective of the patient. It will make you to carry I don't like to use the word carry the patient along, because it's like you are walking and you are dragging the patient with you. No, the patient is an active participant in that care. But if you view the patient as being somebody who is just there waiting to be helped, then you are now going to be the expert. Tell the patient, okay, use one medication morning and night. If the patient tells you what medication is it, just shower low, one in the morning, one in the night. Which means the patient does not have the right to know what they are using, does not have the right to know what you are doing for him or her. Now, if your perspective is that the patient has the right to self-determination, then before you give a patient a medication, you have to explain to the patient, okay, because of your blood pressure, and you know it's been resistant, so we are going to give you two medications, one for your flu to make you pee so that you can reduce your blood volume, and the other one will dilate your blood vessels. However, this other one will give you some side effects. For example, it can make your leg to swell up sometimes. So when it happens, you raise your leg up. Now, the patient is fully aware of what they're going to, and the patient has the right to say, oh, I don't want the one that will make my leg to swell. Can we have another alternative? So it depends on how we view reality, that we can construct our theories or even interpret existing theories. Now, there are four dominant paradigms in nursing: empiricism, interpretivism, critical social theory, and postmodernism. We've talked about them under the philosophy, and I told you that our paradigm is just an extension of nursing philosophy. However, when we talk about empiricism, we are talking about numbers. We are talking about reality as being stable. If the patient blood pressure is 120, the patient is fine. And if the patient blood pressure is 220, the patient is ill. So reality is stable based on these numbers. It is objective, it is measurable. Knowledge is acquired through observation, experimentation, and statistical analysis. So example of some of the research methods could be randomized control trials. We do surveys and data analysis. So these have also influenced our nursing practice. When we do evidence-based practice, I love evidence-based practice, but because I'm more of a phenomenological person, I have a reservation with evidence-based practice. Now, evidence-based practice means that, okay, if we have done this, we've realized that this is the best solution. So everybody that comes to your unit, you apply that solution to the patient. But that does not justify that does not put into consideration that human beings are also different. That what works for this person may not work for the other person. So your care should actually be individualized instead of evidence-based, because evidence-based is based on what worked for majority of people. So you see how our philosophy, how our paradigm also influence the way we approach clinical practice. Okay. Yeah, that is what empiricism is talking about. That is one worldview of empiricism. Interpretivism, we've talked about it already. Reality is not fixed, so there's no single reality. Depends on how you perceive a situation. How you perceive situation. So you can't say 2 plus 2 is not 4. Somebody can see 9 as 9, and somebody can see it as 6 from a different perspective. So reality is not fixed. Reality is there are multiple realities. So everybody experiences things differently. Now, because one thing worked for me does not mean it's going to work for a different person. And that's why understanding experiences of people with certain phenomenon is one of the ways to understand how different people perceive a particular experience. So in this case, we use qualitative research in order to, through interview, case study, or ethnography. Okay. Critical social theories talking about health equity, health disparities, gender and race and class, how they affect health outcomes. There are theories that also propound that. Madeleine Leininger also deals with that a little bit in such a way that we go to the culture and see how men are in some culture, men are the breadwinners. So they are the ones that go to the farm, look for food, and feed the family. And then the women are the ones who give birth in some culture, and that is how. So you have to understand how these cultures, how their social life is, and understand how you can introduce some health measures that can make them to become healthy. And then lastly, the postmodernism, it talks about all this, it's also related to the metaphysical, where we have Margaret Newman, we have Rosemary Passay. I was supposed to meet Rosemary Passay in DC, Washington, DC, but unfortunately she couldn't come. She sent me a LinkedIn message that she was not going to be there because of personal issues. And she's old. So her theory of human becoming tells us also that things are not seen from one fixed perspective. Things are dynamic. Reality is dynamic. Reality is, depend on who is experiencing it. And she talked more about quality of life. Quality of life has been more important than even the treatment you are giving. I attend some workshops where chemotherapy or oncology companies, pharmaceutical companies come to present their medication and their theories and how their medications have been effective in order to encourage us to, prescribe it to our patients. However, one question I always ask them is, even though you have done this research and found out that your medication is effective, can we have evidence of the quality of life of these patients that have survived using your medication? And most times there's no answer. because people are not looking at it from this postmodernism perspective. They are only looking at it from the empirical. If 90% of people are fine, then we say this is effective. However, how about their quality, the quality of the care of their life? Some people will prefer to die than to live like a vegetable. So even though empirically you say you count them because they're still alive, you count them as being survivors. But then in reality, to them, they are not survivors. They are even better dead than in their state. So we should always look focus on quality of life according to the postmodernism, quality of life, and how people can, even with illness, how they can live well, how they can appreciate reality, appreciate themselves as human person, and even transcend beyond the present. That is postmodernism worldview. However, Rosemary Passé has summarized that there are two paradigms that we have in two major paradigms that we have in nursing: the totality paradigm and the simultaneity paradigm. According to Rosemary Passé, she propounded that, okay, these are the two, regardless of all this philosophy and worldviews that we've talked about, there are two major paradigms that we have in nursing: the totality and the simultaneity. Totality is that we are recognizing that human beings are made up of different parts. So it is the combination, the summation of these different parts that make us a human being. So somebody can be having abdominal pain, the person will go to gastroenterologist because that is the part that the patient is having issues with. Whereas simultaneity views the person as being uniquely whole regardless of parts, more than the sum of his or her own parts. That is what simultaneity paradigm talks about. Okay, let's talk about the totality first. The person as a whole but comprised of parts. There's causality. So if you don't eat well, you are going to have this problem. And if you eat well, the problem is not going to be there. It's talked about causality and effect, cause and effect. There's also reductionism under totality paradigm, where human experiences, complex human experiences, are reduced to mathematical numbers. We reduce the patient to certain indicators. For example, blood pressure is what is causing the patient to be ill. And once that is addressed, the patient is fine. Oh, blood sugar level is high. Once it comes down, we can discharge the patient without realizing that the patient may be having some psychological problem as a result of being on admission. So our focus on totality view is on disease and cure. Diagnosis, intervention, fix, correct. These are our focus in totality view. The patient has low PCV. Let us treat the PCV, and once the PCV is back to normal, let us send the patient home. Okay, it's more of a military approach. Whereas simultaneity paradigm talks more of, okay, it's more holistic. It views the individual as indivisible. You can't be divided. You can't be reduced to different parts. You are indivisible. You are uniquely whole. You are inherently connected to the environment, and there is this pattern of evolving, pattern of becoming, rather than a static state. It's either you are healthy or you are sick. So it's not static from simultaneity paradigm. It is flexible. Somebody can be having high blood pressure and the patient can live the best of his or her life with good quality of life. Somebody can be having even cancer. The patient can still enjoy life, can be pain-free, enjoy the environment, go out to appreciate nature and things like that. That is what simultaneity paradigm is all about. Health is health. A person is a unified whole. It talks more of holism and focus on meaning of the experience rather than the curing the disease itself. The care we provide can also have an effect on the cure. However, our focus in this perspective will be to care. So these are examples of theories that are based on simultaneity paradigm. Margaret Newman, John Watson, and Rosemary Passé. And these are my, good theories. So now let's talk now about theory itself. Let me check the time and see. Okay. All right. Theory, we have defined theory earlier as being a way to explain, describe, predict phenomena. There are a set of framework, organized framework that we use to explain, describe, predict phenomena. If it is phenomena is anything that can be observed, anything that we can see, anything that can be perceived, they are all phenomena. Anything, just mention anything that is going on around you, they're all phenomena. Okay? Anything it could be somebody that is walking and the person is now on the ground. That is a phenomenon that you have observed. Oh, this person was walking and then suddenly on the floor. That's a phenomenon. That's a phenomenon. If it's multiple, it's called phenomena. Okay? So anything that you can witness through your senses are phenomena. So there are multiple phenomena around us. And I want you to start thinking of those occurrences, those phenomena that you can witness within your clinical setting, within your, even right now as you're talking, there are a lot of phenomena going on. And we can open our senses to see how these things work, how these things are going, things that are occurring. Okay? Now, I can observe from my own perspective, that everybody is quiet. Now, when everybody is quiet, what does it mean? I don't know. Is it that what I'm teaching is really entering into your system, or like you guys are understanding it very well, that everybody is paying attention, or people are distracted, they don't care. Maybe I'm saying rubbish. But then the phenomena I observe is that everybody is quiet. I'm the only one talking in this class. No noise. It could also mean that my network has disconnected and I've not realized that, and I'm talking to myself. I just had to check it now. I see that people are still on the call. We have 34 people. So, but then there could be, yeah, I know. There could be different reasons why everybody is quiet. But what I can observe is the silence from the class, a class of 34 people on this call, but no noise, not even a pin. That is a phenomena that I have observed. Okay, now moving forward, as you are in class now, let us be thinking about different things that we are seeing that we can observe. I would have made this a class activity, but we don't have enough time. So I want you to look at around you. What can you observe? What can you feel? What can you smell? What can you perceive with your senses? What can you touch? In my environment now, classes were canceled today. Every work was canceled everywhere because we were thinking there will be snow again and there will be harsh weather. I'm supposed to fly to Louisiana tomorrow morning because I have a presentation in Louisiana. But my flight was 6 a.m. in the morning, but it was canceled and they moved it to 9 a.m. because Houston airport has been closed. So flying from Atlanta to Houston and then Houston to Louisiana, that has been changed. So I will now be flying to San Antonio in Texas. So the cold weather, everywhere is cold, is a phenomenon. Is a phenomenon. But then I don't know, can somebody mention one phenomenon around him or her right now, or even in the hospital setting, something that you can perceive, you can see, or that is going on? Anything. Can you mention the phenomenon? Anything. Can one person just say anything that he or she can witness, can perceive right now? Okay.
Yes, I can observe here that everywhere is dry. Everywhere is dry and the weather is very dusty.
Okay, weather is dusty. Yeah, you can see some particles of some particles moving in the air, right? That's why you said the weather is dusty, because I do not know what you mean by weather is dusty. But you are perceiving, you can see some things that make you think, okay, maybe this is a dusty weather. And dusty weather, you can tell somebody else, they say, what does that mean? What do you mean by weather is dusty? But then from your own perspective, that is what you can perceive. Okay? Now, that is a phenomenon. By the time you give it a name, or you give it a label, or you give it a name, it becomes what? A concept. It becomes a concept. For example, a patient walking and the patient suddenly is on the floor. That is a phenomenon I observed. The patient was walking now and suddenly the patient is on the floor screaming. That's the phenomenon. But what name can you give to that phenomenon?
Sudden onset.
Sudden?
Onset.
No. I mean, the patient is walking on the hallway or on the ward, moving around, and suddenly the patient falls on the ground or the patient is on the floor. What would you call that situation?
Syncope.
No.
Collapse.
Okay.
Fainting attack.
Emergency.
Fainting attack.
No.
Emergency.
No. That is
Or
simply a
incident.
fall.
Incident.
That is simply a fall.
A fall now, a collapse.
Yeah. I think it may not be collapse. See,
Okay.
and when we are dealing with concept, we have to be specific. The patient, we are not sure whether the patient collapsed. All we note that the patient did what? The patient fell. So that was a fall. It could be that there was a wet floor and the patient tripped.
Okay.
Right? So would you call that fainting? No. It could be that the patient maybe mistook, had a wrong step and tripped on the floor. You can't call that a syncope or syncope. No. All we know is that the patient fell. So that phenomenon that you witness is a fall. We are not talking about what caused it or whatever, but the phenomenon itself is a fall.
Okay.
Now, in your world, if you have a moisture on the floor, what is that called? Moisture on the floor. Let's say the floor was dry 1 hour ago and you are back and you are seeing moisture on the floor. What is that called? What would you call it? Is that a wet floor?
Sorry.
Would that be called a wet? Would that be called a wet floor?
Wet floor, sir.
That is a wet floor. That is a wet floor, right? Now, somebody that fell and has injury on the head, what is that called? In medicine, we can give it a name as head injury, right?
Head injury.
Head injury.
Yes.
Head injury. And the person that had the head injury is not responding. Is not responding, is bleeding, but it's not responding. You call the patient is not responding. What will you call that?
Unconscious.
Unconscious. And eventually, that person that was not responding, but the person was still breathing, is no longer breathing, and no pulse, no respiration, nothing. What would you call that?
Dead.
That is death. That is death. So these are experiences. These are experiences that we observe, that we perceive using our senses. These are experiences that are occurrences that are going on. So they are phenomena occurring, but then because of our interpretation of these phenomena, we give them a label, a name. And that name will represent what is going on. That name will represent what is going on or what we have observed. So the name we give to the phenomenon is called what? Or when a phenomenon is given a name, what does it become?
A concept.
It becomes a concept. Perfect. It becomes a concept. For example, I just wrote one of the articles I sent to you guys last time was an article on time toxicity. And that was the first time in nursing literature will publish a paper on time toxicity. Oftentimes we've been hearing about financial toxicity. We're hearing about medication toxicity, but the concept of hello, I'm getting some feedback. All right. the concept of time in cancer care has not been explored. So it was in the press of, I was just studying, and one night I just got the idea of, okay, time. We are dealing with money, financial, we are dealing with other situations. What about the time? Does time really matter? So when I went to the literature, I explored, I said, okay, what will I call this situation where patients that have cancer, sorry, I may talk more about cancer today because that is my area. Patients that have cancer, especially here in the United States, all their lives are are focused around cancer. Sometimes they miss important events. Sometimes they miss so many things because they have to go for testing, they have to go for follow-up, they have to go for different things. They're always checking for information, checking their note to see if the doctor has written something new or things like that. So time for them is about cancer. So that was why I looked at it. I said, what can I call this? So I gave it a name as time toxicity. Time toxicity. And I said, okay, if it's time toxicity, what then is time toxicity? So I did a concept analysis and I defined what time toxicity is all about. But it actually started with a phenomenon, but then I gave it a name. It became a concept. Now I got a letter recently appreciating me for that work. Okay. The time toxicity is now becoming a concept that is known within the nursing. And right now, I'm doing a research to understand, to develop an index. I call it TTI, Time Toxicity Index, so that when we are caring for our patients, we should not always only know how medication is affecting them. We should also know how the whole situation is affecting their time. So we want to measure time toxicity on our patient. While we are measuring quality of life, we should also measure time toxicity. That is the way I'm going. Anyways, that is the concept. We know what a phenomenon is. We know what a concept is. Now, the next is proposition. Proposition is how we link multiple concepts together to make a bigger meaning. Okay, how we link multiple concepts together. We say concept are the building block of a theory, right? However, that block is not made from, does not just come like that. It came from a phenomenon. And then phenomenon is considered as the raw material, like the cement, the sand, the water you put together to form what? To form the concept, which is the block itself. But one block or multiple blocks cannot make a building. How do you use blocks or bricks? How do you use bricks to make a building? Those of us that have built houses, how do you, here in the United States, we don't use brick to build that. We use wood to build houses. In Nigeria, we use blocks. So how do you use single blocks to make a building? How does it work? Hello, class.
By joining it together, by mounting
Okay.
it on each other and supporting it with maybe cement.
Okay, supporting it with
They
a
mount it
cement.
together.
Perfect.
Yeah.
Okay. And when they are building, you can't put the block just on top of each other like that. It has to be systematically
Yes.
linked. One will be on the
Arrange,
side, the
yes.
other one will be on the side, and then another one on the top will be at the middle, and you
Okay, the
position it
middle.
like that. That is proposition. The ability to link multiple concepts together to give it a general meaning is a proposition. For example, previously we talked about moisture on the floor, right? Hello?
Hello, sir.
Yes, sir.
Hello, sir.
I'm getting a feedback. Are we together?
Yes,
If
sir.
you're not
Yes,
talking
sir.
to me, please mute your microphone, please.
Yes, sir, we are together.
All right. So, like I was saying, we talked about wet floor. Oh, somebody is distracting me, and I don't like that. Please, can you all mute your microphone? All right. Can you all hear me now? Yes, I muted everybody, so you should be able to hear me. So we talked about the wet floor. Wet, a moisture on the floor, we gave it a name, wet floor. A patient walking and suddenly is on the floor, we called it a fall. The patient having injury on the head, we call it what? Head injury. The patient is breathing but is not responding. We say the patient is unconsciousness. And then the patient is now not breathing, not having any pulse. His pupils are dilated and fixed. We say the patient is dead. Now, these are phenomena that we gave names. And now let's look at the proposition, how we can link all these phenomena together. Do you think a wet floor can cause a fall? Hello, class. You can mute now. You can unmute. But please remember, after talking, yeah.
Yes,
Can a wet floor cause a fall?
Yes.
Yes, sir.
Yes, because
Okay.
it will be slippery.
Yeah, it will be slippery. Perfect. Can a fall result in head injury?
Yes.
Yes.
Perfect. Can head injury result in unconsciousness?
Yes.
Can unconsciousness result into death?
Yes.
Yes.
Now, let me ask one more question. Can a wet floor cause death?
Yes, it can.
Absolutely.
Yes, sir.
Absolutely. So you can see that if you are making a theory of fall, I'm developing a theory of fall or fall theory in nursing or theory of fall in nursing, whatever theory you want to give. So you are going to have your basic concepts, your basic phenomena, and you give them a name, and you see how different concepts are interconnected. Okay, wet floor is here now, which can lead to fall. Fall can lead to head injury, can lead to unconsciousness, and can lead to death. You connect them together, and that becomes a proposition, which means you can make an hypothesis and say, okay, there's a relationship between wet floor and death in the clinical setting. There's a relationship between wet floor and unconsciousness in a clinical setting. There's a causal relationship between fall and head injury among patients. So all these are proposition. In theory, we call them proposition, but in research, we can call them hypotheses. Okay? Now, so there are so many things you can think of. You can think of road traffic accident as a concept. You can think of road traffic accident as a concept. When there is a car crash, you say it's a road traffic accident. But what are those things that can result into road traffic accident? Can we talk about it? What are those things that can result into road traffic accident?
Overspeeding.
Overspeeding. Now, what can cause overspeeding?
Overspeeding.
What can cause overspeeding?
Haste.
Good road.
No. You talked about overspeeding. Let's take it from that perspective. What can cause overspeeding?
Reckless driving.
Being haste.
Hastiness on the part of the driver.
Being in haste.
What can make a patient to be in a haste?
Alcohol, drinking of alcohol.
Anticipation.
Hey, let us understand
Anticipation
it.
to reach. Yeah. Anticipation to reach destination.
Earlier, right? What can make somebody to be anticipating to reach destination earlier?
Time factor. Time.
Well, time factor is everything we are talking about. Haste is about time. Hate is about time. But there are other things that can cause it. Number one, personality of the person. Right? Personality of the person can make the person to drive to overspeed. There are people that I've seen, no matter how late they are still driving slow. No matter how late they are. They say, I will shall get there one day. Where there's an adage we say in Igbo that where somebody that is running will reach, the person that is walking will reach there one day. It may not be the same day, but it may be one day the person will reach there. If a runner is able to get there, a walker will still get there. So there are people that have that personality that, well, jeje laye, you take things easy. But there are people, even if they have the whole time, their own is just to reach there early and feel good that they got there before everybody. So personality has also been linked to overspeeding. Overspeeding has been linked to road traffic accident, and road traffic accident has been linked to death. So, do you think personality of a person can cause death? Absolutely. Those with type A personality who always do things fast and who do not see risk in certain things. There are sometimes when I'm driving and people will do certain maneuver, I say, yeah, are these people human beings? How do they think this way that they will maneuver this way and it was just near collision, so many things. So you can, if you are doing a theory of road traffic accidents, you look at those basic things that can result into overspeeding and then link all of them to overspeeding. And then the overspeeding is now linked to road traffic accidents, and which will lead to increased rate of mortality. That is simply how you do your conceptual framework that depicts your theory. But it's just your ability to be able to understand what the basic concepts are and link them together, showing relationship or those phenomena. Then you doing that, you are developing your propositions. I'm doing the research now. I'm trying to understand colorectal cancer screening among African immigrants in the United States. It's funded by my university here. And I'm using health belief model, the construct of health belief model, using them to run a structural equation model to create my own model. Okay, health belief model has its own perceived susceptibility, perceived severity, cues to action, and perceived barrier and all that. But those ones are general. How does this apply to my own setting, the African immigrant in the United States, in terms of colorectal cancer screening? Their perceived severity, does it really make them to go for screening? Who knows? It may not be. Because from the basic data I've collected, some people, when they know that they are likely to have certain condition, they even run away from it. They are scared of hearing bad news, which may be different from the Americans. Because even when they are telling them that they are dying, they want to know, okay, let me know what is going on. But some people, especially within our African context, it's possible that when you know that, they may find one disease, they'll say it's better I don't even know about it than for me to know about it and overthinking will make me die. So it depends on the context. So health behavior among Africans may be different. So if I'm constructing a structural equation model, it may have a different direction other than other people's direction. So I have different basic things that may cause them to go for screening or otherwise. And at the end of the day, I can create a theory from that perspective. So I'm building my theory, a new theory, using health belief model, but then those will be to understand colorectal cancer screening among Africans. Okay? Now, what is an assumption? When you assume, what is going on? It's a question for the class, please. What is an assumption? Yeah. Assumption. We use it every day.
Assumption might be a perception of somebody or a thought of someone that is not really confirmed, or that is not actually the truth. It might not be the truth, but just a
Absolutely.
perception.
Correct. I want another explanation, but that was perfect. Another explanation. What is an assumption?
Assumption.
Mm-hmm.
Assumption is something that you can, agree that it's true, even though it might not be true. If it's
Yeah,
tested.
that is perfect too. That is perfect. I need one more.
Hello, sir.
Yes, ma'am.
Assumption is a statement of proposition that is yet to be proven.
Absolutely. So, assumption is a statement of proposition that is yet to be proven. So, using the examples we have had so far, example of proposition, can you make an assumption? Can you make an assumption?
Yes.
I just made one assumption now. That I said that personality type can result into death, and everybody agreed.
Yes.
But do you have a research that prove that? We don't know yet. So it is still an assumption until we test it. That personality type will make people to overspeed. Okay, that's an assumption. Even though everybody thinks from a logical perspective, oh, it's true. Yeah, those with type A personality, they can take risk. It's an assumption until it is tested. So can somebody give me another example? Benima. Mongoyin. I thought you were talking to me. Can somebody give me an example of an assumption, please? Hey, kí ló ń ṣẹlẹ̀? Okay.
Hello, sir.
Yeah.
We can give an assumption that male students perform better than female students.
Okay, that is an assumption.
Nursing students. Yes, sir.
Yeah, that is an assumption. Yeah, any other assumption?
By next election, President Tinubu will become the president again.
That is not an assumption. That is a prediction.
Prediction. Okay, sir.
Yeah. Because you're not stating a reality. You are stating a prediction, something you say, okay, because he's already a president, we are expecting him to be president. You are predicting, but that is not an assumption. An assumption is something that's happened, and you say, okay, it was this that led to this, or something like that led to that. Okay. All right. So can you say that when a patient fell, like when there was wet floor or something and the patient fell. Okay, let's say when a patient falls and you see that the patient has fallen, is it always a wet floor that causes the fall?
Not always, sir.
Not always a wet floor that would cause a fall, right?
Yes,
what other things can make a patient fall?
A patient can fall if he's not guided with side rail on the road.
Okay, for somebody who's weak that doesn't have side rail, what again?
If he misses, a patient can fall if he misses the step.
If they miss their steps, that's
Yes,
okay.
sir.
What else?
Patients with abnormal gait, unstable gait.
Unstable gait, absolutely. What again? So these are variables that can be connected to fall, right? Of course, patients who are using antihypertensive, who may have orthostatic hypotension, are prone to falling. Old patients. So if you are developing a theory of fall, it's going to have multiple components that are interconnected. And when these components are interconnected, you link them together in the form of a proposition. However, these propositions are mere assumptive until you subject them to a research. Now, research may tell you that, okay, even though it's assumed that patients who have unstable gait can fall, but then based on this research, there was no relationship between unstable gait and fall. So it remains an assumption, but not a tested relationship. So these are the basic components of a theory. The phenomenon, you start with the phenomenon, then concept, proposition, and assumption. All right. So now another thing you need to understand is what is a theory, what is a model? Are they the same? Are they different? Now, theory, we've understood what a theory is, but a model is sometimes confusing. Some theories have said, some authors have said that model and theory are used interchangeably. And some will say that the model is a miniature of a theory, just like a model of a human being, a human heart. A model of a human heart is not a heart, but it looks exactly like a human heart. So a model is just a miniature of the original theory. So when you see the model, you can understand the theory. That is a different perspective. While some say it's interchangeably used. And I see that often revealed in different theory. For example, we have the Roy adaptation model, which is a middle range theory. A middle range theory is calling our theory a model, Roy adaptation model. Sister Kalita Roy, her theory is actually based on the totality paradigm. But then she calls it a model. And this was one of the questions that she was asked when I met her in Manila in 2018. I met her in the Philippines when she came for a conference. So it was one of the questions people asked her, that why would you call your theory a model? Well, her answer was that they are used interchangeably. That if a model looks like a real thing, it's as well the real thing. So that was the perspective they looked at it. But then, so just be aware. Why I brought up this is for you to be aware when you're reading some theories, they may call it a model, but it's a full theory. So based on your interpretation, when you read it, you understand it, then you can know that, okay, this is a full theory or it's just a miniature of what the full theory is. And in most cases, we also use model to represent the diagram that we draw to represent our theory. For example, we have the Bertin-Newman system model, which is also another model, but that's a grand theory. Bertin-Newman's model is she drew one beautiful diagram that talks about flexible line of defense, normal line of defense, lines of resistance. Okay, her model tells us about the primary prevention, secondary prevention, and tertiary prevention. Her model itself, the diagram itself, when you look at it, you would understand how our body interacts with the environment. And when we interact negatively, it results into stress. And these stressors can cause illnesses. So her diagram represents the theory, but then it is just a miniature of what the theory is all about. Okay? Now, theory and science. What is theory? What is science? What is research? Science is a combination of theory and research. It becomes science. It becomes knowledge. Of course, science is, reality, what can be observed, what can be empirically measured, and things like that. So how do they come by? Remember, we talked about a fall, we talked about wet floor, talked about somebody having head injury and death. These are mere propositions and maybe limited to the level of an assumption. However, if we subject this into research and see how wet floor will result into fall, and how fall will result into head injury, and head injury into death, we can now say categorically that there's a significant relationship between wet floor and fall. There's a significant relationship between fall and head injury. There's a significant relationship between head injury and death. that becomes science. Okay, so in reality, science is when theory is tested. The outcome of this testing is what science is all about. And that's why some people are fighting qualitative researchers even till today. Even among nursing field, some people still say that qualitative research is not real science. It's a pseudoscience or something like that because science is more of empirical. Whereas we say science is something that can be perceived, something that can be that you are witnessing, and lived experience is what the individual witnesses and shows evidence of their own lived experience in certain context. So we also call it science, even though we may not test it in reality because you can't measure experience of somebody. You can't measure how somebody feels about the way you talk to them. You can't measure it. You can't measure their perceptions. You can't measure their feelings. Even though nowadays people are working so hard to measure some of these qualitative constructs. For example, quality of life. You can't measure quality of life, even though we have measures for quality of life. But in reality, quality is quality. You can't just subject it to some questions that you put on the questionnaire. That may not really reflect what that quality of life means, except the patient tells you, narrate the story, tells you the essence of their experience, tells you a story that depicts those experiences. Then you can now interpret it and say, oh, this is what this patient is feeling. Anyways, so this diagram talks about theory, which is combined with research, tested in research, giving us science, and science in nursing is nursing science. And so when we say we are doing Masters of Science in Nursing, or Bachelor of Science in Nursing, or Bachelor of Nursing Science, there has to be a theory component, there has to be a research component. And the combination of these two gives us the science in nursing, which is a nursing science. So theory can be used to describe, explain, predict, while research can be either qualitative or quantitative or a mixture of two. When they're connected, it becomes science. So there's nothing, we can't talk about science without theory. So there's nothing like a theoretical nursing because theory is the body of knowledge that makes us professionals. Okay. Let's talk about classifications of theory, and then we'll now go straight into how theories are developed. I hope we have enough time. This class is not what we do within 3 hours. So I don't know how we're going to do it, but let's continue. So theories are classified based on different criteria, either based on scope, based on philosophical or perspective, or based on their purpose. Based on scope, there are 4 major classifications, but we talk more of 3. So we have the grand theory, we have the middle range theory, and then the practice specific theory or situation specific theory or practice theory. There are different ways we call them. The grand theory is the grand. It does not prescribe anything for nursing. It just gives us the whole how nursing is viewed generally. Okay, it is so abstract. It is so unspecific. It is so broad that we can't even use it to make the decision. It just talks more of a philosophical or theoretical underpinning. I'm skipping meta theory. Meta theory is when you do theory that is built on another theory. So it becomes meta theory, just like we do meta analysis. But the major ones are the grand theory, which is grand, complex, broad in scope. Okay. At this level, if I ask you to develop a theory, I won't say you should do a grand theory because grand theory you have to be embedded into philosophy, embedded into so many underpinnings that will guide your development of a grand theory. Nowadays, nobody develops grand theory again because people will use already existing grand theories to build new theories. So if you are building a theory, it's going to be middle range or practice theories. Example is Orem's theory. Orem's theory, it does not talk about a specific area. It's just general, nursing generally. Nightingale talks about general. Margaret Newman and Betty Newman, there are 2 Newmans there. One is Margaret Newman Margaret Newman talks about health as expanding consciousness, whereas Beth Newman talks about the system model, that the individual is a system, works like a system. And then Rogers, Martha Rogers, is her theory is science of unitary human beings that we talked about. They are all grand theories. Okay? We can't use them to prescribe interventions. No. We just use them to develop insights about what nursing really looks like generally. Okay. Now, the next one is the middle range, which is a bit limited in scope, but still more, I wanted to say more scopy, but which is more broader in scope than the practice theory. It is in between. The example is Kokaba's theory. By the way, what is the name of Kokaba's theory?
Theory of context.
Absolutely. What about Swansea's? What's Swansea's, Christine Swansea's theory?
Theory of caring.
Okay. What about Leininger, Magdalene Leininger's theory?
Culture care.
Culture care, diversity, and universality. What about Nola Pender? Nola Pender. What about Nola Pender's theory? Pender is a common theory in nursing. Hello.
Health promotion.
Yeah, health promotion. All right. Then the baby of them all is the practice specific. Practice specific is more of prescriptive to a particular setting. Orem's theory can be used in psychiatry. Orem's theory can be used in oncology, can be used in perioperative, can be used in anything. But theory of postpartum depression cannot be used in cannot be used in cancer. Theory of postpartum depression cannot be used in let's say gastroenterology. Theory of infant bonding cannot be used in orthopedic, even though it depends on context. Oncology pain management cannot be used in diabetes. So practice-specific theories are specific to a particular area, a particular field of nursing. So it tells us, if it's prescriptive, it tells us how that particular aspect should be handled. For example, if I develop a theory of diabetic self-care management, it gives you how self-care management in diabetic patients should be handled, which is specific to diabetes self-care management. So when you are reading theories or when you are examining theories, you should also realize, the scope of each of these theories, and that will guide you in also developing your own theory. So now, these are theories classification based on scope. Now, there are also other classifications based on the type or the purpose of the theory. Remember that we said theories are a set of organized frameworks that are used to describe, explain, predict, or prescribe phenomena in nursing. So which means the 4 kinds of theory based on the purpose is descriptive theory, explanatory theory, predictive theory, and prescriptive theories. So the descriptive is also called factor isolating theories, because all they do is just to describe. They do not tell us connection. They just tell us, okay, this exists. So when we do certain scoping review, we use that to develop descriptive theories. They just tell us this is what is existing. They do not tell us any relationship or any connection. That is descriptive theories. Okay? We can do literature review. We can do concept analysis just to describe certain concepts. We use that to build factor isolating theory. Now, for explanatory or factor relating, we explain how one variable is connected to another variable, and that is our factor relating. We are relating one variable for and connect it with another variable, which is head injury or unconsciousness. Okay, That is factor relating. Then the next one is the predictive. Predictive is when we draw a predictive model and say, okay, for fall is being predicted by the prevalence of wet floor on the unit. So we can say that when we change a variable, it's going to affect the other variable. So if we want to prevent fall, we have to make sure that the floor is dry as possible. That is, if you have done the research and has found a high predictive effect of wet floor and fall. Remember, there could also be other reasons why a patient may fall, which we have explained. But then if your research has found wet floor as the major predictor, then you can develop a predictive theory of fall using wet floor as a major predictor. And then the last one is the situation specific, situation producing rather, or prescriptive. Those ones tells us, okay, this is how we do things in nursing. For example, Orlando's theory of the nursing process is a prescriptive theory that tells us for all patients, you must do an assessment, you must do diagnosis, you must plan, then implement, and then evaluate. That is a prescriptive. It tells us how we follow certain things in nursing. Of course, they are rational because you can't do anything without doing an assessment. And that assessment will involve both doing quantitative assessments and qualitative assessments. All right. So example of descriptive I said before was concept analysis, literature review, grounded theories. They just are there to describe what can be observed. They are not making any major connection. They're just telling you this is what exists. Okay. Explanatory will tell you, okay, I'm explaining the relationship that exists among these two variables. For example, it tells us how and why certain things occur. So when we do certain correlational research and find out that wet floor is highly correlated to falls, then we can explain that fall, in the theory of fall prevention in nursing, wet floor is a major aspect that we need to consider. Predictive, we make a predictive model. I'm using a what is it called? A structural equation model to make a predictive model to see how certain variables will predict colorectal cancer screening among African immigrants in the United States. Okay, so by the time I'm done and I'm creating a theory from it, it's going to be a predictive theory, which says that those, I can say maybe depending on my results, that those with insurance are more likely to go for screening than those without insurance. Even though at this level, it is more of an assumption or a proposition, but then when I test them, it may be a prediction. Okay, and so the theory that comes out from it will become a predictive theory. And then prescriptive tells us this is how we do things, how we do things. For example, Orlando's theory will tell us that we have to make use of the nursing process. Now, based on the philosophical underpinnings of these theories are classified as need theory, interaction theory, outcome, and humanistic theories. Need theory, when the patient is in need, the role of the nurse is to solve that need. Who can give me an example of a need theory? That your role is to help the patient to meet certain needs when they are in need. Or, yeah, who can give me an example of a need theory based on this philosophy?
Virginia Anderson. Virginia Anderson.
Anderson's
14 needs.
No, Anderson is not. Yeah, Anderson. Yeah, Anderson is also there. Another example.
Self-care model.
Self-care. That is RM self-care. Perfect.
Abraham Maslow, sir.
Maslow. Even though Maslow is not a nurse, but we also use it to we consider it very relevant in nursing. Perfect. So these are need theory because the theory is telling us that the individual has a need and the nurse is there to assess the need of the patient and help the patient to meet those needs. We have the Abdel's 21 nursing needs. These are also need theories. What about interaction theories that revolve around relationship that exist among nurse and the patient and the environment? What example of interaction theory do you know?
Florence Nightingale theory.
Nightingale theory is more of a need theory. Does not tell you relationship that you build with your patient.
Okay.
Plaza.
Yeah, absolutely. Hildegard Peplau. Yeah, absolutely. Which one again?
Yes, theory. Let's think about it.
Now, talk about King's. King's goal attainment is considered both interaction and outcome. Now, King's talk about how the patient comes with his own action, his own perception, goals, and issues, and the nurse is also coming, but then the two of them will be at the same wavelength for there to be an action, a reaction, interaction, and then achievement of goals. So it also deals with interaction. It's an interaction theory, even though it is also an outcome theory. Any other example of interaction theory that deals with your connection with your patient?
I've forgotten.
Theory of caring.
Theory of caring is a humanistic theory. Okay. What about outcome that sees the nurse as the changing force who enables the individual to adapt or cope with ill health?
Adaptation.
Roy's adaptation. Yes. Roy's adaptation is there. What else?
Yeah. Roy's adaptation.
Yeah, Roy's adaptation is correct. What again? Which one is another outcome theory? We've talked about King's. King is an outcome because King tells us that the nurse will be there to initiate that interaction, and then there will be action, reaction, transaction taking place. That is an outcome theory. Another example of an outcome where the nurse is the changing force that drives the process to bring about a change that help individual to adapt or cope with ill health.
Yeah.
We have forgotten all our theories.
No. Theory of comfort.
Yeah, theory of comfort is also an outcome theory. Perfect. That is by Kokaba. Yeah, theory of comfort. Now, let's go to humanistic theory that emphasizes the capacity for self-actualization, that tells the nurse believe that the person has the potential for health and creative growth. So self-actualization, you are dealing with a human person. You are not dealing with an animal that is just a passive participant. You are dealing with somebody who has the right to interact, has the right to make decisions, has the right to self-actualization. Example of theories in this category.
Abraham Maslow, sir.
Maslow, fine. Even though Maslow is not in nurse, but it's also there. Which other theory?
Is it not dealing with needs?
Yeah, dealing with needs, but then it also transcends to self actualization.
Actualization.
Yes.
All right.
What of Passes theory, sir?
Passes theory is humanistic, absolutely. Rosemary Passe is humanistic, perfect. We have John Watson's theory. We have all these are humanistic theories. All right, let's go to the meta paradigms of nursing. Then we'll now talk about the connection among all the things we've been saying since morning. There are 4 meta paradigms in nursing. Of course, they are proposing a 5th meta paradigm. They are proposing a 5th meta paradigm, and that is, they are They are proposing. Well, it's been long. They proposed that even though it was not carried, was not agreed by the scholars, but somebody proposed that we should include social justice as part of the meta paradigm, but that did not fly. Anyways, so hitherto, for now, we have the four meta paradigms: the person, environment, health, and nursing. And this meta paradigm also reflects on the philosophy we talked about, reflect on our paradigms and worldview, the lens we are wearing. Some theories will see a person as somebody who is in need, who is there waiting for the nurse to care for him, or waiting for the healthcare providers to do things for them. That's the way they view a person. But somebody else will see a person as somebody who is, who has a right to self-determination and has a right to be involved in his or her own care. So depending on the worldview that you are having, that will also determine your definition of a person. If you are constructing a theory, that your worldview, that your philosophical underpinning will be consistent throughout. Even in your model, when you are drawing your diagram, your philosophical underpinnings will be consistent. Also reflect on how you see a person, how you interpret a person, how you define a person. Is the person an individual, or is the person a group of people? So if your theory is theory of family cohesion, let's say I'm just forming that now. I'm designing for a theory of family cohesion. A person may not be an individual. A person may be a family unit. So you see how your theory, your philosophical underpinning, your variables will determine how you define the meta paradigms. Environment. What is environment? Environment can be defined depending on how your theory looks like. For example, some theory will say that we ourselves are environment. Our internal environment is part of our environment. Our immediate external environment are all part of our environment. I have one of my students in one of my previous classes. They developed a theory, and one of her definition of environment is nurses are also part of the patient environment. So how do we constitute a positive environment for patient, and how do we constitute a negative environment for patient? There are some patients that feel uncomfortable when certain nurses come to their unit. I don't know if you have heard that some patients call nurses witches, Aje, the nurse here. See her with her big bum bum. See her with her this and see how she's. Some patients feel that way, depending on how we treat them. So we can constitute either a positive environment to patients or even a negative, depending on the type of theory you're creating. And then what is nursing? Also, depending on your worldview, depending on your philosophical perspective, if you are a postmodernist theorist, nursing will be you are just there to facilitate the process. You are not even doing anything for the patient. You are facilitating the caring process. The patient will do things by themselves. You connect with the patient. You ensure quality of life. You include family members in the care you provide. That may be nursing. In some situations, nursing is doing things for the patient, doing for. So it depends on your meta paradigm. So if you are designing your theory, reflect on these things so that your meta paradigm will be consistent with all the content of your theory. So now let us look at these two worldviews. All patients are dependent, and the nurse's role is to carry out all activities that the patient cannot do themselves. Paradigm 2, all patients need to be independent, and the nurse's role is to encourage patients to do as much as they can for themselves. Now, if you are working with any of these worldviews or paradigms, how will it influence the way you care for your patient? So let's say you are working with paradigm 1. How will your care for a patient in paradigm 1 differ from the care you provide to a patient in paradigm 2? Let me hear you speak. At least one person should talk. Hello, class.
Hello, sir.
Yes, ma'am.
I don't understand the question, sir. Hello, sir. The question again, sir.
Read paradigm 1 on your screen and paradigm 2. How will your care for a patient in paradigm 1, let's say in hospital A, they are using paradigm 1, and hospital B, they are using paradigm 2. How will your care in paradigm 1 differ from your care in paradigm 2?
Okay. In paradigm 1, sir, I want to talk. I want to just make it. In paradigm 1, meaning that we are going to give holistic care, total care to that patient, because the patient cannot do anything on her own. So it's the nurse that will carry everything out for that client. So,
Okay.
but in the patient, the patient has been doing, little things. He's been getting out of the problem and is now doing little things. So we have to encourage the nurses now. We have to encourage the patient to do more as he can do for him. That is what I can understand from the statement, sir.
Okay, that is correct. Yeah. So for paradigm 1, the patient is always, we call them patient because, what does it mean to be patient? When you are patient.
The person that is sick.
Okay. What does it mean to be sick? What's the definition of sickness?
Hello, sir.
Yes, sir.
When somebody is sick, it means that he is unable to do those routine activities that he has been doing, which somebody has to do for him.
Is that correct? Is that your definition of sickness? So can somebody be sick and still be able to do their activities like they are sick?
Yes, sir. They can still do some activities, sir.
So how would you now define sickness based on ability to perform activities of daily living? So you see that there are multiple truths, there are multiple realities in life. Because I do not believe in a single truth. I believe in multiple truths, that people have different ways of viewing things. Now, somebody can have a mental, not really mental, but somebody can have some disturbance, is disturbed spiritually. Is that person sick? Yes, if you are going by WHO's definition, but can the patient do things by themselves? Absolutely, they can.
They cannot do.
Okay, it depends on the level of mental spiritual disturbance. For example, if somebody is worried about the kids, if somebody is so fearful that I hope my kids are okay, they may still do certain things, but even though they are worried, and within them they don't have any physical impairment, but within them they are sick based on the definition of WHO, because health also has some spiritual or mental component. So for paradigm 1, the patient is dependent on the nurse, and the nurse's role is to carry out all activities that the patient cannot do. In paradigm 2, all patients need to be independent, and the nurse's role is to encourage patients to do as much as they can for themselves. Now, which one do you think the patient will recover better? Is it 1 or 2?
Two,
because recovery can be defined as the patient's ability to do things by themselves, and not necessarily absence of disease.
Disease of infirmity.
Absolutely. When the patient recovers, the patient may still be, of course, for example, there are lifelong conditions, for example, hypertension. The patient has hypertension, but the patient has recovered. The patient is not sick, even though the patient has an illness, hypertension, but they are not sick. So if they're able to do things by themselves, they are still having that infirmity in them, but they are okay, they are discharged, they are living their lives. Okay? So if you continue to do things for the patient every time, it does not encourage it does not encourage independence, and that may prolong the patient recovery or state of independence. Now, we've talked about the relationship between theory and paradigms. It depends on what you view, how you see the things, how you see reality, which paradigm you are wearing. Is it the totality or the simultaneity? Do you see the patient as a patient, or you see them as an active participant or a human person? One philosopher says that a human person, that is I've forgotten his name, and I wrote about him though, that a human being is unpredictable, is rational, unpredictable, and has a sense of self-determination. That was Aristotle. It was Aristotle that stated that. So if you see a patient to be somebody with self-determination, how do you, for example, now, if you go to the hospitals, I don't know where you guys work. Let's say you go to OAUTH, Obafemi Awolowo University Teaching Hospitals. Are patients allowed to see their case notes? Are they allowed to see their case notes?
No, they are not allowed.
Why?
No, they are not allowed.
Why?
It's everywhere, sir. They are not allowed. Confidentiality.
Confidentiality about my own condition, about my own diagnosis, about my own illness. I'm the one that is sick, and you are doing confidentiality on my own condition. What type of confidentiality is that? Now, you see where paradigm is coming into place. If you see that a patient is just there waiting for you to do things, you are the doctor or the nurse is the expert, then we can continue to practice in this way. But if you see a human person, a patient, as a human person who is unpredictable, who has the right to self-determination to make decisions about him or herself, I don't see any reason why I will come to the hospital complaining of abdominal pain. You draw my blood. I was the one that felt the pain for the blood draw. I was the one that paid the money for the laboratory analysis, and the result comes out. You say I cannot have a copy of my result or case notes. I don't know if it's making sense. So if we are acting that human beings are like robots, they are just there. We are the one in charge. They are just, we are reducing them, subjecting them as, mathematical numbers. They are patients. I've seen 20 patients today. It's just, I've seen 20 patients. That's what a biomedical model talks about. How many patients have you seen today? But how many persons have you worked with today? Because the person has the right to his or her own body. That is one of the assumptions of Roy's adaptation model. The person has a right to knowledge about him or herself. So depending on how you feel, how you view reality, how you view worldviews, how your worldview looks like, how your paradigm looks like, that also determines how you practice nursing. Here in the United States, we are moving from the biomedical view to a human caring perspective. I do laboratory. I get the results directly on my phone, or they send me a copy. The doctor may have a copy, and you don't discuss my condition to somebody else without my consent, because it is my condition. It's my laboratory result. I paid for it. It's about me. I was one that came to the hospital. You didn't come to the home to say, hey, you must come to the hospital today. No. How come my case notes, when I'm looking at my case note, you hide it and close? Who told you have more right to me than me myself? I'm not saying it's right. I'm not saying it's wrong. I'm just saying that it depends on the paradigm we are working with. So when we are designing our theory, if our paradigm is the totality view or the empirical view, then we can continue this way. But if we are looking at the simultaneity, that human beings are whole, we are not there to fix them. They are whole. regardless of their illnesses, they are continually whole. Then we are working on the totality paradigm or the phenomenological perspective. So, yeah, we've talked about Rosemary Passay's two major perspectives. So, yeah, we've talked about the meta paradigms in nursing, person, how they view things. Somebody can say the mind, the body are inseparable, while others may say that the human person is a unity and cannot be viewed separately. Okay? Nursing, some people view nursing as a helping profession. You help the sick to perform those activities. While somebody else will say that nursing is just caring for the person, and allow nature to attend to their natural infirmities. While others will say you just modify the environment. That is Nightingale, modify the environment and then allow nature to settle the patient. So is health an absence of infirmity? To some people, yes. Health is when the patient does not have any illness. But to some other people, for example, to Margaret Newman, health is not an absence of infirmity. Health is how the lived experience of the person within that situation of infirmity. Somebody can still be healthy with diabetes, according to Margaret Newman. Somebody can be healthy even while they are healthy deaths. While they are dying healthy, meaning they are dying happy. Unfortunately, within our Nigerian context, palliative and hospice care is still not well established. We want to do all our best until the person gives up. Whereas in some other places, when they see that the disease is really advanced and they just go for hospice, and the patient, you see them. We had the former president of America, Jimmy Carter, that died few weeks ago. He was in hospice for a long time. He got to a point, he said, okay, let's go for hospice. And we were just making him comfortable. He was meeting with his children, grandchildren, enjoying life while he knows that he will soon die. So making preparation pain-free. So that could also be defined as health, even at the verge of death, in the presence of infirmity. So it depends on the worldview you are carrying that you define. Talonja. Eh? I hope they are not giant in my class. Okay. So environment, the same thing. So now, the key stages of theory development. Theory can be developed in different forms. I know we have overstepped our time. Theory can be developed in different forms. It can be developed through research, can be developed through concept analysis, can be developed through different way theoretically. Okay, it can be inductive or deductive. So, but then most times theory, before you build a theory, you have to start with a concept, like we've talked about. So you can develop a concept by observing situation, giving it a name, and then clarifying what that concept is all about. These are the concepts that I've worked on. Time toxicity. I've also worked on humanization of caring, of nursing, because I've been a simultaneity person for so many years. So I talk about those things that cannot be measured quantitatively, but qualitatively. So I've written about humanization of caring and then responsive sensing. Okay, responsive sensing. Yeah. There are a lot of concepts that you can work on, you can develop, and then give it a meaning, clarify the meaning. Then you can now also develop a conceptual framework that talk about a visual representation of the relationship that exists among the concepts. Remember, we talked about four. You can create a diagram that is logical, that can show how these variables are connected, leading to death, and call it a conceptual framework of theory of four. Okay, in nursing. So it gives us a blueprint. Okay, if the theory says that wet floor, alcoholism, use of certain medication will result into unsteady gait, and this can result into fall, can result into head injury, eventually will result into unconsciousness and death. That becomes the conceptual framework. So if we want to prevent fall in the hospital, we need to address some of those variables that are connected to fall in the first place. And if we want to prevent head injury, where fall cannot be 100% prevented, we need to put some things in place. For example, there's something we call fall mattress. If a patient is in at risk for falling off from bed and we can't prevent it 100%, we can put some mattress on the floor. They call it fall mattress. And when the patient falls on the floor, the patient will not have head injury. So this theory can give us a blueprint on how to really approach, human caring. Then you now create a propositional statement to see, okay, there's a connection between this and this. There's a relationship between this and this. This is connected to this. These are propositional statements that you will make. And these propositional statements will be reflected in the conceptual diagram that you already created. The two actually work together. And then after you've done that, you now validate your theory empirically, test it in real world, check for reliability, applicability, and then get data to see how each of these variables are connected. And if some variables are not connected, you expunge them from the model that you already created. And then you refine it and revise. And that becomes a validated theory. Many of the theories that we have today have been validated, and that's why some of them have come up with certain measures. Some of them have come up with certain questionnaires or survey that can be used to test some of the concepts in their theories. And me, time toxicity, I'm also validating my own theory, hoping that very soon I will have my own index on time toxicity in cancer care. So theory can come from different ways. Through practice, you observe things, observe the phenomenon. Hello? Observe things, observe the phenomenon, give it a name. From giving it a name, you look at the various components, you connect them. Hello, some people are talking without muting their microphone. All right. So can also be research-based, such as the one I'm doing on structural equation model. Hello, can we all mute? This is etiquette in online classes. If you are talking before you talk, check that you are muted or not. Double check that you are muted or not. All right. So you can start with concept analysis. This is just repetition, model building, hypothesis testing, and then you test it in research and practice. Now, after you have created this research, you tested it in clinical practice, and they are validated. How do you evaluate these theories? You have to evaluate them based on clarity. Are the concepts clear? And the relationship that you have defined, are they well explained? Is this simple? There's something we call parsimony in theory. It's not supposed to be too simple and also not supposed to be too complex. Who can give me the simplest theory that you know? The simplest that is just direct.
Florence Nightingale's theory.
Nightingale's theory is not really simple, but it's a grand theory. Maslow's theory is simple. I know Heidegger Paplau is also simple. Everybody talks about it. But who can give me a very complex theory?
Pinky Mode.
Yeah?
Pinky Mode.
Which one is Pinky Mode?
Yes.
Pinky?
King Imode.
Which one is King Imode? There's no King Imode. Oh, Emoji King. Okay. Okay. King's is very simple. I love King's model. If you look at the diagram, you know that it's very simple. very simple to follow to do. Yeah. But then the idea is it shouldn't be too simple that it makes no sense, and it shouldn't be too complex that people will not use it. If you read Rosemary Pass's theory, you will sweat. You will sweat. Her theory is well, not really complex. It's just that the terminologies she used, and that started from when she started the theory. Our theory was first called theory of man living health. Now, because the feminism came up and they're saying man is genderized, so she now changed it to human becoming. That's why she moved it from man living health to human. Human is general, human becoming. And then what does it mean to become? He talks about waves. Talks about waves, just like Margaret Newman. She talks about waves, talks about pattern, talks about opposing view. If you read that theory, you'll say, oh, what is she really talking about? Now, there's also supposed to be empirical precision. That your theory must be tested, should be able to be tested. People can use it and test it. For example, the health belief model is I love that theory too, because you can test passive susceptibility, you can test passive severity and see how they interact with certain health behaviors. And then there has to be a derivable consequence. Does the theory guide practice? If yes, then it's a good theory. If no, then reconsider. So these are the things you have in mind that will make you to develop your theories effectively. Now, while developing theories, you should not repeat what is already existing, otherwise it becomes redundant. So you should be thinking about what are the current trends in nursing theory, what are the current situations that your theory can align with. Now, the global perspective, there is what is currently going on globally. We are talking about health disparities. We are talking about cultural sensitivity. We are talking about so many things. So if you are developing theories, it should reflect global perspective. Your theory should also reflect emerging areas. For example, integration of AI is an emerging area. So can you develop a theory that can combine a human side with artificial intelligence in order to bring about improved care to our patients? One of my professors during my PhD, her theory is technological competence as caring in nursing. So the perspective of that theory is that while we are caring for people, especially in the ICU, most times we are dealing with gadgets and forget that it's a human being we are taking care of. We check the ventilator setting, we check the blood pressure, check everything, and forget that sometimes human touch, speaking to the patient directly, dealing with the patient like a human being, even though they are not talking, is very important. So that's his own perspective in the theory. So culturally specific theories are what we need. These are current trends that when you are developing a theory, you should be looking at these areas. Challenges in theory development, of course, there continues to be theory practice gap. There continues to be a testing issue, while some theories are difficult to test in research. So if you develop your theory, make sure that your variables are well defined so that they can be tested individually and correlated. And of course, there's always bias in theory development. Majority of our theories are from the Western countries. I developed my theory in 2018. I promote it, I've published it, I keep promoting it, but because it's from somebody of African descent, it's a bit difficult for the global world to even accept. So, but we are still working towards that direction. So there's still a bias. So, yeah. So these are just a reflection of what we've talked about. In theory development, you identify the phenomenon of interest. You do a literature review. You do your concept development, either through concept analysis. You check for proposition, the relationship that exists among the concept. Then you construct the assumption. We've talked about this already. I'm just repeating it. You create your theoretical proposition. Draw a diagram. It doesn't have to be complex. If you are putting an arrow to connect your variables, you have to define why the arrow is going down or going up. It's not just arbitrary. If you view that the nurse is always on top and the patient is down, then the arrow can go in that direction. But if you view that the nurse and the patient are on the same level, they are all human beings, all doing their role as either a nurse or a patient, you can put them on the side and connect them with an arrow or connect them with whatever. So the position of your arrows and connections should be intentional, not just by aesthetic purposes. For aesthetic purposes, it should be intentional. And then you develop your framework, you test the theory in research, and then you refine. Then you apply it into nursing. And of course, theories will be evaluated continuously. Jane Watson has evaluated her theory multiple times, that her theory has evolved to something different than what she started with. So, this is where we are going to end it, because it's 9:10. Yeah, it's past the time. So concept analysis would have been the one topic we'll have gone through, but we don't have enough time, so we'll just leave it at that end. You guys can read on that. When I send the slide, you can read on the concept analysis, how it's done. It's just to clarify a concept. Yeah, the concept could be what does it mean for caring to be humanized? What does it mean to put humanism in the care you provide? So you now dissect it, get information from different fields, and then you define that concept within the context of your theory. That is what concept analysis is all about. So I'm sorry we couldn't go beyond that, but I think the concept analysis is the last part of the lecture. Are there comments, questions, or clarifications before we call it a day? But I will post the slide, and if you have a question, you can always reach me. I am busy, but I will try. Any question or clarification as to how philosophy drives our theory, and how theory is now tested in research, and the culmination of everything is to improve nursing science and the care we provide to our patients? Are there comments, questions, or clarifications? Are there comments or clarifications? Otherwise, we call it a day. If there are no comments or questions or clarifications,
thank you very much.
Yeah.
Thank you so much.
Thank you very much.
Thank you, sir. We appreciate you, sir.
No problem.
Sir.
Yeah, thank you.
Thank you so much, sir. Are you still coming up?
Is that?
I said before exam, are you still coming up?
Well, I have to discuss with Professor Esson.
With our dean?
Yeah, with your dean. Yeah, I have to discuss with her.
Okay, sir.
Yeah. All right. And then I will try to see how I can merge the videos and send to you. Sometimes larger videos are difficult to send, so I have to upload it to YouTube and then send you the link to watch from there. Okay?
Yes, sir.
All right.
Yes,
thank
sir.
you very much, everybody, for your participation.
Thank you, sir.
Yeah. Thank you. Yeah.
Thank you.